Are patients now, as they're having their biopsies, are all tissues being tested for these various mutations, or do patients have to, in advance, ask their doctors for testing? What is the protocol now? Because this is the essence of personalized medicine.
Well, obviously, there are differences from one side of the world and the other side of the world, because obviously, if you are talking about Asiatic patients, they have much more probabilities to get EGFR mutations. So EGFR mutations are tested almost routinely in Japan and the Asiatic countries. There is the tendency, at least inside the United States, I'm saying not North America, I'm saying in the United States, to test almost every patient for EGFR mutations. But we know from the beginning that the higher chances to get an EGFR mutation are related to adenocarcinoma, women, and never smokers.
You mentioned CMET. This is yet, for many people, they've not heard of this before. They've heard of KRAS, they've now heard of ALK, but you're throwing in new variations. What's the status of that sort of testing?
Well, we should say that it's still experimental. When you are looking to the possibility to implement a diagnostic test, you need to be sure, because the test should be reliable, should be validated, and we are not still in such position. The EGFR mutation testing is fully validated. We are in the process to validate, for instance, the ALK FISH test. We are not sure that the ALK FISH test is the right test to test the presence of the ALK translocation. It's quite likely that 1 year from now we will be able to get back to you with additional information.
I think what's most striking about what we've been discussing, I think maybe more so in lung cancer than any of the other cancer types right now, is how individualized this disease is, and the possibility and the importance of genotyping. And I've never heard such rich discussions about the value of one's tissue and what it means to look for genetic mutations and characteristics which will individualize their care. And it's such a paradigm shift as we talk about cancer, and it's very important for patients to realize, one, the responsibility they have to encourage their tissue and their specimens to really be analyzed, but how hopeful it is that these are tailored therapies. And I think lung cancer just represents where we're at with personalized medicine. It is the ultimate in personalized medicine, and it's a disease that we couldn't have had this discussion 15 years ago in this positive light.
So my key takeaway messages for you and for all the patients are no more than 2 or 3. The first one is the following. We know now that almost 20-25% of non-small cell lung cancers they harbor specific mutations. This is mainly true for never smokers. But when you are considering 100 cases of non-small cell lung cancer, few years from now, we will be able to genotype 20% of these 100 cases. In these 20% of the cases, quite likely we will be able to detect the right target that is driving proliferation, and we will be able to apply the right targeted therapy. The second take-home message is that we are, as you said, we are in a sort of moving target. And what is true today during this interview cannot be true anymore 1 year from now. And this moving target needs the increase of the proportion of patients who are getting biopsies not only at baseline, but also the time of the relapse or recurrence of the disease, and probably even later. Because it's quite likely that the disease at baseline has a morphology, as it has probably a genotype, and this morphology and this genotype, it could be completely different at the time of the relapse. As well as I'm not sure that the genotype of the primary tumor is the genotype of the metastatic site. So I would like to encourage any patient to interact with the clinician, with the medical oncologist, and to discuss with him when is the right time to make another biopsy. Obviously, the second biopsy is coming in a bad period of time, usually, because the patient has more symptoms, has the effects of the chemotherapy, is feeling worse, and so on. But the possibility to check the biological status of the disease is critical. That is exactly what I told you. We are on a rolling field, on a moving field, and this is extremely important. And what about the other 80%, you can say? Well, for the other 80%, we are planning pharmacogenomic studies. As you know, I'm deeply involved on that, and we have an adjuvant pharmacogenomic-driven study. Hopefully, we will be able to generate data 4 or 5 years from now. We are doing a window of opportunity study in locally advanced non-small cell lung cancer, again, look into pharmacogenomic and also functional imaging using diagnostic instruments like PET and MRI. And we are also thinking to do a pharmacogenomic-driven study in the elderly patient population together with a couple of US institutions.
So that means next year at this time, we're going to be sitting down with you and we're going to be hearing about a whole new slew of genomic characteristics in tumor types that we don't yet know today.
I hope to be able to sit with you and to update you and your patients about that.
Thank you for this comprehensive and rich overview, Professor Giorgio Scagliotti from the University of Torino right here in Italy.
Thank you for inviting me.
Thank you so much.